I would like to thank the organizers for inviting me to come down here to talk about a topic that has been a focus of our center for quite some time. I should acknowledge that our work has been supported by the NIH with a center grant from NIDDK and the Office of Research of Women's Health. What I thought in this talk, since it's a conference about with a particular focus on women, to slightly have a different focus than the speaker that preceded me. I will not delve into the therapies of IBS, should say as a disclaimer. Unfortunately, there is something, again, similar to fibromyalgia, and I'll come back to many of these similarities in my talk. There's no FDA-approved therapies that are readily available at the moment. The two that were approved in the last few years have either been most recently taken off the market or are available in a very restricted form. So I will not talk about this. However, I will focus on something that we have been quite interested in, and this is the question: is there something unique about women to develop IBS and related comorbid disorders? And I'll show you a series of studies that we have done at our center, continue to do to better understand, are there vulnerability factors that predispose women to develop these disorders, and ultimately, will there be opportunities for a better treatment that's targeting so sex-specific differences within the nervous system. I should also acknowledge in the beginning my co-workers, Dr. Lin Chang and Dr. Bruce Nalabov, who have contributed essentially to many of the things that I'll be showing you in this presentation. So, as you've heard several times, and Leslie certainly emphasized this point, amongst this group of pain disorders, we're very familiar and we're very good in treating so-called structural disease or organic disease that causes pain. Pain is the warning symptoms in these disorders. It's acute. When the underlying problem is treated, then the pain goes away. This is different in these so-called functional disorders where you basically cannot easily identify a organic or physical cause for the disease, such as inflammation or tissue damage. Treatment has been very unsatisfactory. And you can see that there's sort of counterparts to the pain from peptic ulcer disease, so-called non-peptic or functional dyspepsia. Feels very similar, but this occurs without the ulcer. This is with the tissue lesion. Similar in terms of pain coming from pelvic organs, irritable bowel syndrome, the most common of these functional syndromes. So far, really without any generally agreed upon alteration in the within the GI tract, as opposed to inflammatory conditions or malignant conditions where we have a very distinct cause of the pain, and the pain usually goes away when this underlying problem is taken care of. In terms of IBS, there is a process, a so-called Rome process, because a committee meets every few years in Rome and sort of updates these diagnostic criteria. This is not necessarily driven by science, but really by providing a relatively homogeneous and generally agreed upon set of criteria to do clinical trials. These criteria are less often used in clinical practice. It's somewhat like the DSM-4, but it's been looked at by investigators in this field sort of as a mixed blessing, because it really hasn't helped to understand what's underlying this. So this is the so-called Rome 2 criteria: 3 months history of lower abdominal pain or discomfort associated with altered bowel habits. This condition is important because if the lower abdominal pain occurs without any change in the bowel habits, then it's referred to as chronic functional abdominal pain. Somewhat different pain syndrome. So these are the points that I want to touch on during these next 40 minutes or so. I'll say a few words about the epidemiology. Then I'll discuss this point. What is unique about women in the development of chronic disorders of pain, and I listed here affect because, as you've heard in the previous talk, there seems to be a important overlap between a whole range of conditions that are characterized by physical pain and discomfort and emotional pain, as depression and discomfort, like in anxiety. And then I'll show you some of the emerging data on these what we think are important sex-related differences in neurobiological mechanisms. So in terms of the epidemiology, and I have to say it's always fascinating to see if this were a conference where people talked about fibromyalgia, interstitial cystitis, IBS and other functional gastrointestinal conditions, this would always be very similar. So you have a large pool of patients, of individuals in that normal population who do not see healthcare providers, who have positive symptoms using these diagnostic criteria if you send out questionnaires and people cross on what kind of symptoms they have. But for example, in the US, this reservoir of individuals who meet the diagnostic criteria for irritable bowel syndrome is the majority. These people will generally not see a physician. We don't know exactly what they do. They pretty self-medicate. They go to alternative therapies, over-the-counter types of remedies. What is important in these population-based samples, about 70% are women, 30% men. This is important because one aspect of the greater prevalence of IBS, many of these disorders in women, has originally been attributed to a greater healthcare seeking behavior of women. And this is a legitimate factor as well. Women in general, when they have any type of physical pain or discomfort, are more likely to seek help and healthcare for these symptoms. It's probably one of the factors why women get older in our society, because they're more vigilant towards the body and do something about it. Men try to suppress it and go on with their lives. So it's important that individuals that even don't seek healthcare, you see the significant gender difference. These are very common disorders. You saw this earlier figure from Leslie. These are probably the most common chronic pain disorders that we know. And again, you may not be able to say pain disorder because it occurs in the normal population. Many times the pharmaceutical industry tries to lump all this together, but we have to consider these are not individuals that would necessarily seek treatment. So about 25% of the people that have the symptoms will seek healthcare, the majority in primary care, a small portion in specialized centers, in the case of IBS, gastroenterologists, and even smaller, at the very tip of this pyramid, are the psychiatrists who see a highly selective group of individuals who have gone from here to here and apparently have not gotten beneficial treatment. So some people have suggested that the only group of individuals we have to be concerned about as physicians or as healthcare providers are really the ones in the top third of this pyramid. And efforts have gone into determining what is it that makes an individual who has the symptoms down here to actually become a patient, so go from a non-consulter to a patient. And factors that have been identified, this probably have been the most consistently, the severity and frequency of the abdominal pain has come out in several studies, impaired health-related quality of life, and I'll say a word about this in a minute, and obviously the accessibility to the healthcare system. These numbers are quite different in countries where there's easier access to the healthcare system for everybody, so universal healthcare than compared to the United States. Now this is important because what goes into this tremendous impairment of health-related quality of life, so just to give you an example, IBS patients, if you give them a health-related quality of life instrument, will rank their quality of life impairment similar to, for example, I always use that example, patients with chronic renal failure who are on dialysis. So it's hard to understand that somebody who has to be on dialysis 3 times a week would have a comparable impairment. What we know in the meantime is that factors go into this that have very little to do with the actual IBS as we define it. They have to do with fatigue, loss of energy, inability to function properly, sleep disturbances, decreased sexual drive. So a whole range of vital function impairment that we also see in the other disorders such as fibromyalgia. So it's conceivable that factors other than coming from the GI tract really play a major role of who will ultimately seek healthcare. And it's conceivable also that people with or patients with different types of somatic symptoms will seek healthcare driven by this impaired quality of life, but they go to different specialists because they sort of identify with a particular symptom as opposed to somebody else who picks a different symptom. Now this is this concept of the overlap. As a gastroenterologist, I started out being interested primarily in irritable bowel syndrome. In the meantime, our center really has expanded into interstitial cystitis and fibromyalgia, and we firmly believe that these are a group of related disorders, and we're trying to understand what is it that they share and in which way are they different. In this schematic from Dan Claw, it's shown here. Look at IBS, the largest one of these disorders occurring 10 to 15% of the population, and others that are much smaller. One that received a lot of attention, the so-called Gulf War syndrome, fibromyalgia, and psychiatry somatoform disorders, chronic fatigue syndrome. Not listed here, interstitial cystitis and other chronic pain conditions. So one of the questions is, and this is sort of our working hypothesis, is it that there is a shared CNS abnormality that makes patients share many of these clinical features in addition to certain kind of peripheral factors that may give specificity to a particular syndrome? And our group has sort of focused really on characterizing what those mechanisms might be. If we look at the data that has accumulated, suggests that there's something that makes women or the female sex a major factor in a major risk factor. So we know from the prevalence, regardless if you look at population-based samples or in clinic-based samples, there is a significant greater number of women who have IBS and seek healthcare for IBS. Female sex is also a major risk factor if for this entity, some of you may have heard about this so-called post-infectious IBS, individuals that have an acute documented gastroenteric infection, and then after the infection goes away, the symptoms stay. Again, women are much more likely to develop this entity than men. If you test patients, and we use a pretty archaic way of doing this by inflating a balloon in the colon, in the sigmoid colon or in the rectum, women show the greatest degree of this hypersensitivity to balloon distension. And then also the overlap, the comorbid conditions are more common in, much more common in women. So clearly there is a factor that plays a major role. And so what is unique in the development of these disorders of pain and affect, including IBS? I mentioned that earlier. We do know from epidemiological studies that there are gender-related differences in behavioral responses to physical and emotional distress. A woman is more sensitive to, or listens more to her body, and secondly, will do something. The threshold for actually seeking healthcare or help for these symptoms is lower than men. One thing that we have focused in our research, that are there sex-related difference in brain circuits that play a role in causing the symptoms, and I'll spend some time on this. And then there's an interesting series of factors, both genetic but also these epigenetic factors that shape behavioral and biological responses to stress, and I'll give you a few examples of that as well. So if you look at these factors, let me just give you 3 examples that I find particularly interesting, and a lot of research has gone into this. Some are just beginning really to be investigated. There's a prominent role of early maternal-infant interaction in shaping the responsiveness of the central stress response. And this has been shown to play a role in combination with the genetic makeup. There's also studies that have shown there's an important role of mothers as a role model for behavioral responses to physical emotional distress, other than the direct physical emotional contact with the infant. And then this is a very intriguing thing that it's just the beginning. I thought I'd throw this in because you may be reading about this in the press, receiving a lot of attention. There's also a prominent role of maternal-infant contact in shaping the intestinal microflora. You may never have thought about this, but you will see many papers and newspaper articles on this in the future. And I'll give you sort of my speculation because we haven't really begun to comprehend this in terms of its potential role in a disorder like IBS. So let me start with the first one, these early maternal infant interactions and how they interact with genetic factors in basically setting the vulnerability of an individual early on in life, that later, if this individual on the trajectory is exposed to certain psychosocial or physical stressors, so in terms of gastrointestinal symptoms, surgery, antibiotics, infection, tissue irritation, it's the individual that has a greater vulnerability based on genetics and these maternal-infant interactions that is more responsive to stressors and more likely to develop anxiety or chronic pain disorders later on in life. There's other factors that kick in later that also may be genetically determined, cognitive factors that have to do with how this individual thinks about their disease, and then this construct of symptom-related anxiety, how much you're worried about the symptoms that you have developed. What's interesting is that this model is become the standard model now both for psychiatric and these functional disorders, again emphasizing that we're probably dealing with some factors that are quite similar. So what are these? So I mentioned these early life events, the maternal-infant interaction that plays a role in the interaction with the genetic makeup of a newborn. What are these factors? We know this from psychiatry, and similar studies have really identified these factors in functional GI disorders as well. It's really the quality of the maternal-infant interaction that's influenced by prenatal stress to the mother. We know a lot about this, the factors of abuse in early life. The death of the mother, a greater risk factor actually being the divorce and prolonged marital troubles between the parents and this cold, distant mother-child relationship. Shelley Taylor has referred to this as the risky families that play a role that sort of impair this quality of life. We do know that from many studies in psychiatry and also some from GI, that this increases the vulnerability for affective and physical disorders as an adult. And what's exciting about this, we have actually some very good animal data that support this and have identified the mechanisms all the way down to the molecular mechanisms. And what is being modeled here, you can see here, it's a particular maternal behavior, this licking and archback nursing of the pups. So it's not the behavior in general of the moms, but it's very specific behaviors that show a strong correlation, you can see this here, between the stress responsiveness of the adult rats once they've grown up from being pups, not just in terms of behavior, so these rats are more anxious. The ones that have been licked less and have had less effective maternal contact, they're more anxious, they are anhedonic, and very excitingly, there's a whole range of molecular changes that have been identified in all the systems of brain modulation, including the noradrenergic system that you have heard about earlier, that has become one of the focus for novel treatments. So just to give you one example, I mean, this has been studied by the pioneering studies by Michael Meany, that, for example, glucocorticoid receptor expression in the brain or the receptors for benzodiazepines are all influenced directly through this mechanism in a lifelong fashion, basically determining the stress responsiveness of the adult animal. So this is not just a psychological, these rats feel better. I mean, they have a different brain depending on how their mother, how their mom interacted with them in the first 2 weeks of life. I also mentioned to you that there is another factor, so this epigenetic influence, that despite the genetics or in addition to the genetics, the maternal behavior plays a role in increasing the prevalence. In this study by Ronna Levy, she has shown that in the twin study that monozygotic twins have a higher prevalence of IBS as expected, emphasizing the genetic component. But what was most interesting is that the presence of IBS, in particular the presence of illness behavior in the mother, so the likelihood that the mother would actually seek healthcare for the symptoms, was an even stronger predictor than the genetic factors. So the behavior of the mother, in terms of the mother's own IBS, is a great predictor of the prevalence of IBS in these children, and potentially a greater factor than the genetics. So this is sort of summarized here. I showed you the effect of these maternal-infant interactions on gene expression, which basically will change gene expression lifelong in terms of many systems that are essential for brain function, but also probably later in life, the modeling of maternal illness behavior through a more cognitive mechanism. Now from these, both of these are established, validated by studies, mechanisms how mothers have an important role in determining the expression of IBS in their children. This is sort of getting more into the Star Wars thing, and we don't know where this is going to really lead to. There have been some theories with the ability to genotype the entire microflora that we have inside of us, so the microorganisms that are primarily in our large intestine. We know that there's more microorganisms in our intestine than cells in the entire body, including the nervous system. A magnitude of a tenfold increase in the total number. So there's more other inside of us than our cells. Here is the most interesting part of this in terms of the mothers and this women's health aspect. We do know that the genetic composition of this, referred to as the microbiome, so the genetic makeup of these 100 trillion organisms is transmitted from the mother to the infant in the first few days in life and remains stable for the rest of an individual's life. So this huge, some people have referred this as another organism that we have inside of us, is influenced by the mother in a non-genetic fashion early on in life. We don't know if it's through breastfeeding or through the infant going through the birth canal. But once it's transmitted, this individual is basically shaped by the mother. Now these organisms are not just sitting there, they're producing all sorts of things, including molecules like norepinephrine and serotonin, which interact with the GI tract and then from the GI tract back to the brain. So we have something sitting in us that nobody of us has ever thought about or looked at, but which we now, for example, one of the most dramatic studies that has come out of this, that obesity is to a significant degree related to a specific set of, to a specific genetic makeup of microorganisms that secrete molecules that affect the metabolism of the individual that has these bacteria. So there's more to come, and I think clearly another very important factor how mothers influence their genotype and phenotype of their offspring. And there is this indirect evidence, there's bits and pieces. Some people have started to treat IBS patients with antibiotic. You may have heard about this. Others have found abnormal from cultures. So there's very early data that there may be something different. There's also the first genetic studies that have shown IBS patients have a different genetic makeup of this microflora than healthy controls. Is this possibly the factor that makes individuals, even though we have commonalities with fibromyalgia, that makes it a unique GI syndrome? This will have to be shown in the future. So let me spend some time about these sex-related differences in the responsiveness, what I like to refer to as the emotional motor systems, circuits within the brain that respond in response to perturbation or anticipated perceived perturbation of the homeostasis of the organism. So this could be a psychological stressor, this could be a threat, this could also be a physical illness. That activates a system in the brain that then goes out to the body and modulates the functioning of the body. Just sort of illustrating this here, and you've seen this slide in different variations during this conference. You heard about the stress mechanisms in the beginning of the conference, and we have the HPA axis, we have the autonomic nervous system, but we also, as part of the system, have the endogenous pain modulation. So in response to a stressor, you not just release ACTH and glucocorticoids, but you also change the perception, the sensitivity to somatic or visceral stimuli. So to give you one example, a soldier in combat who is in a life-threatening situation will shut off somatic pain sensitivity almost completely. An individual who is tremendously worried about something to happen, possibly during the course of the day, but is not really in a life-threatening situation, will do the opposite, will turn up the gain of the somatic sensitivity and become more sensitive. So the brain will not just do one thing in isolation, but the emotional motor system will sort of generate an integrated response that adapts the body anytime to an emotional state or a stressor that goes on centrally. So in terms of the GI tract, we know that the autonomic nervous system plays a major role in the contractions of the GI tract and the secretions. We also know that this pain modulation system plays a major role in the sensitivity of the GI tract to natural and experimental stimuli. And we also are beginning to understand, this is sort of a stepchild, how the glucocorticoids together with the autonomic nervous system regulate immune function within the gut. The gut does have the largest immune system, even though it's spread out, but the mucosal immune system is one of the largest components of the overall immune system in the body, and that makes sense because there's this huge interface. Mentioned the 100 trillion bacteria that constantly interact with our inside. So finally, we have pretty good evidence that these alterations in motility and secretion are the underlying mechanism under altered bowel habits such as constipation, diarrhea, or an alternating bowel habit, and that this enhanced a perception of visceral stimuli is probably the main cause for abdominal pain and discomfort. We also are beginning to understand that there are certain molecules within the brain, such as this global chemical switch, the corticotropin releasing factor, or CRF, that if injected into the brain of animals will trigger all of these. So you can get actually a very stereotypic response. You can produce IBS in a rat by injecting CRF into the brain. Or in another way, if you stress a rat and give it an antagonist to this molecule, will basically prevent all these peripheral manifestations to unfold. What's very important here is that in terms of the emotional motor system, the psychiatric manifestations or these vital functions that I mentioned earlier, they play a big role in the quality of life impairment, such as vitality, sleep, but also libido, eating behavior, anxiety and depression. are also closely related or can be mimicked with pharmacological or genetic manipulations of the system within the brain. So from our viewpoint, it doesn't make sense to, as many gastroenterologists or patients do, focus on one aspect of this. When you have IBS, you have a global dysregulation of an entire system that involves both non-GI related factors, which may actually play the biggest role in quality of life impairment, and a sort of stereotypic pattern of changes within virtually every aspect of your body. So let me say a few things about this visceral perception. We're going to start here, and the mechanisms, particularly what do we know about these sex-related or sex-based differences. And so we do know from surveys that female IBS patients report more somatic symptoms than male patients. So you give them a questionnaire with a wide range of symptoms. You will see that bloating, for example, is more common, urinary urgency, muscle stiffness, even something like altered taste and smell seems to be more common in women. So somehow there appears to be an alteration, not just in terms of visceral sensitivity, but also perception of visceral somatic stimuli in general. Lin Chang in our group has done a pretty comprehensive study using this experimental stimulus, so inflating a balloon in the sigmoid colon, in the rectum, before and after a sensitizing procedure. So basically you provoke the nervous system in simplistic terms to respond to this stimulus, and then you test your sensitivity again. And we did this, she did this in healthy males, in male patients with IBS, in healthy women, and in female patients with IBS. What you can, so just to emphasize one thing, there was no, if you just look at the discomfort thresholds obtained with this paradigm, this is sort of the standard paradigm to test visceral pain sensitivity in humans. There's no real difference between the healthy males and the control males, indicating that there's actually very little presence of a hypersensitivity in terms of the viscera amongst the males. Most interesting, if you just focus on the women group here, if you look at healthy women, so when they were first tested with this uncomfortable rectal distension, they had a significantly higher discomfort threshold where they would call this experiment uncomfortable. When then they got this repeated distension of the sigmoid colon and were retested, they showed this sensitization. Now, if you look at the patients, if you go first from the baseline, they were much more sensitive than the healthy women, and with this repeated stimulation, they became even more sensitive. So women, when they're healthy, seem to be the least sensitive in terms of the viscera to distension, to pelvic viscera to distension. And IBS patients lose that mechanism of this endogenous pain inhibition. And women, as opposed to men, show this phenomenon of wind-up or sensitization with a repeated stimulus. It's been also shown in fibromyalgia with repeated somatic stimuli that women, particularly women with fibromyalgia, show greater sensitization. But this is sort of interesting. So we don't know exactly what the cause of this is. We think that the women have developed systems of endogenous pain inhibition, particularly for the pelvic viscera, to decrease discomfort once the woman knows this is a safe situation. So they can inhibit this, possibly by descending endogenous pain inhibitory systems. And women with IBS have lost this ability. So one of our biggest working hypotheses is there a loss of endogenous pain inhibition in women as it relates to the pelvic viscera? We saw the same thing in terms of the intensity ratings of these stimuli. So here are the healthy women with increasing distension pressures who showed the least intensity ratings, and female IBS patients should show the greatest, with males in the middle, and no difference between the between the patients and the controls. So this is clearly something very unique. Our working hypothesis is this, that women have, in response, in a stress-related condition, such as IBS and possibly other dysfunctional syndromes, exhibit or express the abnormality primarily in terms of altered perception and greater sensitivity, whereas men or male patients do not show this to the same degree. And this is shown here. Autonomic nervous system responses. Remember that one of the output pathways of the emotional motor system is in terms of the sympathetic and the parasympathetic nervous system in response to not just a psychological stressor, but also any kind of emotion will have this output to the body. So it's a normal response. Just show you two examples highlighting an interesting point. So we compared healthy subjects, males and females, with IBS patients, fairly large group, and we found that in this sympathetic measure, so the sympathetic nervous system is one of the systems that's activated in response to a stressor, at baseline and at different situations during this balloon distension paradigm. So the IBS patient showed a greater sympathetic response, but then if you broke it down into male and female patients, we saw that this difference really came only from the male patients. The female patients really did not show an abnormal response. So very different from the perceptual alteration that we see in the women. In this case, the sympathetic response is primarily present in the male patients. And this is just looking at another one, the vagal tone, cardiovagal tone. In general, it's not the more relaxed, the more in homeostasis an individual is, the higher the vagal tone. So this is the good part of the autonomic nervous system. Again, we saw the group difference between IBS patients who had a lower cardiovagal tone as opposed to the control subjects. And if you look at who makes up the difference, it's really the males that have this lack of cardiovagal tone as opposed to the females. So men with IBS show greater sympathetic tone in response to pelvic visceral stimulus and lower cardiovagal tone, whereas women and female patients show this to a much lesser degree. And so you might call this the yin and yang of responses to pelvic visceral stimuli. Males showed particularly or primarily an autonomic abnormality, and women showed particularly a sensory or perceptual abnormality. So the fundamental difference, at least in this disorder and with this particular stimulus, that distinguishes. So the symptoms are same if you assess them with these Rome criteria. The underlying biological mechanisms are quite different. Okay, now let's get to the brain responses. Clearly, we have the bias that some of the things I've showed you in terms of perception and autonomic responses are related to differences within the brain. And there's clearly a lot of folk wisdom about what the differences between the male and female brain may be, and I'll be happy to share this slide with you for a more detailed inspection. What we did with using functional MRI and PET imaging to look both at the normal, so sex differences in the healthy brain, and then also see what the differences may be in the patient populations. This is in response to a pelvic visceral stimulus, healthy subjects, males and females. This is the combined response. This is sort of a very typical response pattern that you get activation in the insular cortex, which we know in the meantime sort of encodes the sensory intensity of a stimulus, and in the dorsal anterior cingulate cortex, which accords the affective and motivational dimension of the pain. So how unpleasant it is and what you're going to do about it. Now if you compare the males with the females, you see that there's much less activation in these areas in the males, even though it's in the same regions, much lower activation than compared to the males. So it's sort of counterintuitive. You would have thought that based on what I showed you earlier with this increased perception, female patients also showing greater emotional ratings of these experimental stimuli, that you would actually get a greater response in the women. But keep in mind, these are healthy women. These are not the patients. The abnormalities I showed you earlier were obtained in patients. So we've sort of developed a concept about this, that healthy women actually have a system in the brain that counteracts the response to a stressor, particularly a pelvic pain stressor, and thereby decrease the brain response. And we actually could confirm this in a study that we published last year, where we looked in different brain regions, so from the amygdala, the anterior cingulate cortex, the insula. We looked at, we counted the voxels, so these little dots in these brain areas that are activated and the ones that are deactivated. And then we formed this ratio between deactivated and all the voxels, and this is particularly important. You see that women shown in pink here show a much greater degree of this ratio, so they show a greater degree of deactivation as opposed to activation. So women in response to this stimulus, when it's given in a very moderate, mild intensity, actually deactivate more of the brain than they activate. And again, pointing to a mechanism that I think is like you could call it a resilience factor or a protective factor for the brain. This difference is not there when you go to a truly noxious stimulus. Again, this makes sense that if the thing becomes really dangerous, then this deactivation is shut off. Now, if you look at the patients, this was a study we actually did earlier, but I show it because it follows these normal findings. Most of the areas in the brain were activated similarly in men and women with IBS, but we also looked at which areas women activated more than men. And you see the amygdala now, same region that in a healthy woman is actually deactivated in the women. And other so-called limbic areas such as this infragenual cingulate, but I just want to draw the attention to the amygdala. The areas that were more activated in the male patients are cortical or cognitive areas, the insular cortex, and areas in the brainstem that includes this endogenous pain inhibitory mechanism. So what we think is that, and clearly based on this is a speculation, that there's a so-called cortical limbic inhibition that activates endogenous pain inhibition mechanisms in the male patients, and therefore you don't see the sensory abnormality that you see in the women, whereas women with this greater limbic response really activate these pain facilitatory mechanisms that amplify the pain. Let me just skip through this. Now we took this same data set, just to give you an example, we'll not get into the details of this. We took this same data set and applied a very sophisticated analysis. We want to know not just how these regions differ, but is there a whole network that we can identify that is differentially activated between women and men in response to stimulus. This is the procedure that we use, and again, it's not the setting to discuss this in detail, but just want to show you the result, which is pretty exciting. So we looked at a pre-hypothesized set of regions that we see in our activation studies. We show these for women, males, these are all patients. At baseline, during the actual stimulus and inflation, and during the expectation of a stimulus. What this analysis does, so you can see in the background, these regions are all linked neuroanatomically. For example, this is the insula, the amygdala, the brainstem, anterior cingulate cortex. What's shown here is only these connections that are different between males and females in this paradigm. And in blue are inhibitory, and in red are stimulatory interactions. And I just want to emphasize particularly this one, where you see a very different kind of connectivity. Look at the amygdala again, this major region of the brain that regulates emotion, but also pain amplification. A nearly opposite regulation of the connectivity in the amygdala, shown here with these stimulatory outputs in the females. This is probably the reason why we saw greater activation in the amygdala, as opposed to inhibitory regulation in the males. So what we can do now, we can actually take these brain responses and not just say, there's greater activation in one region, but we can actually construct a whole network that underlies the sex differences. And what we also know from this analysis that it's only about 15% of the variance that differs between male and female patients. So the majority of the brain response is the same, but 15% show a very distinct abnormality that we think in terms of these abnormal amygdala activations and connectivities can translate into the peripheral manifestations in terms of autonomic and perceptual alterations. So to summarize these brain imaging findings, women with IBS show greater responsiveness of central emotion and arousal circuits, both in terms of in response to an actual distension, but also just expecting or anticipating this unpleasant sensation to occur, whereas healthy women show the opposite, reduced brain responses of these circuits, deactivations, to mild but not more aversive or painful stimuli. I'm glad we found this. When we first had these findings, we presented this at women's health meetings. There was always an uproar. Do you want to bring us back to the time when men could say that women can't drive buses or be astronauts because they have a greater emotional responsiveness? However, we now have this piece of data which is actually quite intriguing, that healthy women seem to be much more resilient to these stimuli. And something breaks down when an individual becomes a patient. And remember now, we talked about these early maternal-infant interactions and a variety of environmental genetic interactions that may be responsible for this breakdown of this normally protective system. So I want to end here. So just summarizing this is a schematic of the brain-gut axis where the gastrointestinal tract is connected to the central nervous system. We have a pretty good understanding of all these pathways, how the information goes up to the brain, to the insular cortex. I mentioned this to you. This is really the viscerosensory cortex, the part of the brain that is able to create a conscious experience of our interoceptive environment. We think that the most likely abnormality in this entire system, very complicated system, is in these brain regions that are the circuitry that include the amygdala, the dorsal cingulate cortex, the hypothalamus. They play a major role in the modulation. You can see these descending pathways that can both up and down regulate pain sensitivity. A lot of work has been going on in this field of characterizing abnormalities in the periphery, at the gut level. But we strongly feel from these advances in being able to look at the living human brain that the main abnormalities up here, that the main reason for the sex differences that we observe, not just in IBS but also in other functional disorders, are related to an abnormal connectivity and activity within these circuits. And the new therapies, some of which Leslie has talked about before, do have a significant impact, just as they do on depression and anxiety, on the interactions and the circuitry that is involved there. Thank you for your attention.
The Diana Paddleford Binkley Foundation helps facilitate dialogue between Western physicians and alternative medical practitioners in the diagnosis, treatment, and management of pain in women.